I was assigned pernicious anemia this week. The case introduction includes JK, who is a 26-year-old male with chief complaints of overall feeling terrible, problems talking, inattentiveness, and memory loss, paresthesia in his legs, and trouble walking sometimes. He presents with pallor and fatigue, and in the past 2 days he has experienced concentration and memory issues. For the past 3 months, he has experienced some numbness and tingling and weakness in his bilateral lower extremities that has increasingly worsened and spread to his upper extremities. He also has experienced changes in his gait, and he has become more unstable, especially in the dark. Episodic shooting pain that begins in his neck and radiates down his back and through to both arms occurs as well. The patient has no prior medical history of conditions or diseases. His listed family history includes his father's alcoholism, his mother's history of bacterial thyroiditis, resulting in hypothyroidism, and the patient takes no medications. The patient does have a history of genital herpes. He has been hospitalized previously at ages 17 and 20 for alcohol detoxification and cocaine abuse, and he has had psychiatric evaluations in the past. The patient does not have a history of good medication compliance. The patient did not graduate from high school, but he does have his GED. His parents are divorced. He is a single father of 3 daughters with 3 different women. He is a blue-collar construction worker who does not smoke, but he does admit to a history of excessive abuse of cocaine and alcohol since age 17. The patient has poor nutrition, eating mainly simple carbohydrates, sugars, and fatty foods, and the patient drinks a lot of beer. Vitamin B12 or cobalamin is a water-soluble vitamin that is derived from animal products like red meat, dairy, and eggs. The intrinsic factor is a glycoprotein that is produced by parietal cells in the stomach and is necessary for the absorption of vitamin B12 in the terminal ileum. Once absorbed, B12 is used as a cofactor for enzymes that are involved in the synthesis of DNA, fatty acids, and myelin. As a result, B12 deficiency can lead to hematologic and neurologic symptoms. B12 is stored in excess in the liver. However, in cases in which B12 cannot be absorbed for a prolonged period, like dietary insufficiency, malabsorption, and a lack of intrinsic factor, hepatic stores are depleted and deficiency occurs. Vitamin B12 deficiency has 4 primary etiologies. Autoimmune. Pernicious anemia is an autoimmune condition in which antibodies to intrinsic factors are produced. Anti-intrinsic factor antibodies bind and inhibit the effects of intrinsic factors, resulting in an inability of B12 to be absorbed by the terminal ileum. Type 2 is malabsorption. Parietal cells in the stomach produce intrinsic factors. Therefore, any patient with a history of gastric bypass surgery may be at increased risk for developing B12 deficiency because their new alimentary pathway bypasses the site of intrinsic factor production. In patients with normal intrinsic factor production, any damage to the terminal ileum, like in a surgical resection due to Crohn's disease, can impair the absorption of B12 and lead to a deficiency. Other damage to the small intestine, like inflammation from celiac disease or infection with the tapeworm, may also result in a B12 deficiency. Type 3 is dietary insufficiency. Vitamin B12 is stored in excess in the liver. However, patients who have followed a strict vegan diet for about 3 years may develop B12 deficiency from a lack of dietary intake. Type 4 is toxin exposure. Exposure to nitrous oxide can cause vitamin B12 deficiency and neurologic symptoms. Another toxin or drug that can cause this is metformin. The pathophysiology of pernicious anemia. In a healthy person, vitamin B12 is bound to the R factor that is secreted from the salivary glands. Once this binding occurs, the small intestine causes B12 to cleave from the R factor by pancreatic enzyme activation. B12 then binds to the intrinsic factor, which is secreted by the parietal cells, which then binds to receptors on the ileum and allows reabsorption of the B12. Once B12 is absorbed, then it is used in metabolic pathways involved in neurological and hematological systems. When this doesn't happen properly, these symptoms malfunction and symptoms manifest. Vitamin B12 is a cofactor for the enzyme methionine synthase, which is used in the conversion of homocysteine to methionine. As a byproduct of this reaction, methyl tetrahydrofuran, or methyl THF, is converted to THF, which is then converted to intermediates used in the synthesis of pyrimidine, bases of DNA. In B12 deficiency, homocysteine cannot be converted to methionine, and thus methyl THF cannot be converted to THF. As a result, the homocysteine levels accumulate and pyrimidine bases cannot be formed, slowing down DNA synthesis and can cause megaloblastic anemia. This anemia then leads to symptoms like fatigue and pallor, which are commonly seen in patients with B12 deficiency. The impaired DNA synthesis can cause problems for other rapidly proliferating cell lines, such as the polymorphonuclear leukocytes, or the PMNs. Thus, B12 deficiency can characteristically result in the formation of hypersegmented neutrophils. Vitamin B12 is also used as a cofactor for the enzyme methylmalonyl-CoA mutase, which converts methylmalonyl-CoA to succinyl-CoA. In patients with B12 deficiency, methylmalonic acid, or MMA, levels will accumulate as it cannot be converted to succinyl-CoA. A hypothesis states that elevated levels of MMA along with elevated levels of homocysteine can contribute to myelin damage, which accounts for the neurological deficits such as neuropathy and ataxia that are seen in these patients. Damage to the myelin can result in a condition known as subacute combined degeneration of the spinal cord. This condition can affect various parts of the spinal cord, including the dorsal columns, the lateral corticospinal tracts, and the spinal cerebellar tracts, which results in a loss of proprioception, ataxia, and the development of peripheral neuropathy and dementia. Clinical manifestations. The patient presents with objective signs of a malnourished male. He is pleasant and cooperative with a slow response time. He appears unkempt and unshaven, tired and restless. His skin is jaundiced and pale. His tongue is beefy red in color and swollen with pale mucous membranes. He has obvious neck discomfort with flexion. He has a systolic murmur over the right sternal border, and his recent memory recall is impaired. The patient also has a characteristic slapping gait, which is typically associated with pernicious anemia. This is a severe cognitive symptom of pernicious anemia that occurs resulting from the lack of B12, which helps to maintain a healthy neurological system. When vitamin B12 is deficient, there is demyelination of the spinal fibers in the spinal cord and the cerebral cortex. This results in a loss of proprioception, causing the patient to be unable to adequately perceive the distance of the ground from their feet. This results in characteristic slapping of the feet down on the ground while stepping. Subjectively, the patient reports a 15 to 20 pound weight loss over the past 3 months. He reports mild burning sensations on his tongue, paresthesia in the upper and lower extremities, and an overall feeling of being unwell. His lab results include decreased hemoglobin, hematocrit, and RBCs are indicative of many different types of anemia, including pernicious anemia or vitamin B12 deficiency. Pernicious anemia can also manifest with a high MCV count, low vitamin B12 levels, a high MCH, a high MMA, a high homocysteine level, a high T bilirubin level, and a high indirect bilirubin level, which is caused by the destruction of RBCs in the bone marrow or intermedullary hemolysis. The patient also has low HDL levels and high LDL levels, which may be indicative of cholesterol issues due to poor diet and alcoholism. Albumin levels are low, most likely due to the alcoholism, and abuse of alcohol leads to liver damage and cirrhosis, which can affect the liver's ability to produce albumin. This inadequate production of albumin can lead to the inability of the body to maintain fluid volume levels in the bloodstream and ineffective transport of nutrients like hormones, enzymes, and vitamins throughout the body. The patient has a blood smear performed, which results in anisocytosis, poikilocytosis, giant platelets, hypersegmented neutrophils, some with 6 lobes, and macrocytic RBCs. Anisocytosis is characterized by irregularly sized RBCs, and poikilocytosis is characterized by irregularly shaped RBCs. Giant platelets and hypersegmented neutrophils typically occur due to cell production abnormalities in the bone marrow synthesis due to pernicious anemia. Hypertension is likely occurring due to compensatory efforts because of inadequate oxygenation in the tissues due to pernicious anemia. This can result in increased efforts of the vasculature to attempt to increase oxygenated blood supply. Paresthesia can manifest as inadequate oxygenation to the tissues, as seen in this patient as well. Role of the advanced practice nurse. Treatment is the supplementation of B12. This depends on the cause of pernicious anemia. If the diet is insufficient, then increasing foods high in B12 or using PO supplementation of B12 is indicated. If pernicious anemia is due to malabsorption due to a lack of intrinsic factor, parenteral B12 is indicated due to a decreased absorption ability in the GI system. And this can also happen in pernicious anemia or in gastric bypass patients. If the cause of pernicious anemia is due to toxins like nitrous oxide exposure and metformin, then the treatment should be discontinued or switched to something else. A thorough neuroexam should be done in patients with B12 deficiency because it can manifest neurologically in severe cases. It is used to determine the extent of damage to the neurosystem. Reassurance, encouragement of a healthy diet that would include higher levels of B12, include red meats, shellfish, fish, eggs, and dairy. And then education for the patient on worsening neurological conditions is pertinent as damage can occur that can be irreversible due to demyelination. Case questions. Identify a minimum of 10 signs in the case study used that are consistent with the diagnosis of vitamin B12 deficiency and manifested by inadequate oxygenation status of the tissues. 10 signs can include hypertension, paresthesia, fatigue, restlessness, weight loss, skin pallor, memory loss, inattentiveness, mucous membrane pallor, and slow response time. These are due to decreased oxygenation status of the tissues in pernicious anemia. The second question is the patient's hepatic function normal or abnormal? In this case study, the patient's hepatic function is abnormal and will likely worsen if not managed properly. This is evidenced by jaundice and will manifest in lab results eventually if untreated, worse than they are already. The liver produces erythropoietin, which stimulates hematopoiesis in the bone marrow, and someone with liver disease, as the patient in the case study is likely suffering from due to his chronic alcoholism, this would be decreased, so the bone marrow does not efficiently produce blood cells, which causes the anemia. The third question is, what is causing the patient's slapping gait? The patient also has a characteristic slapping gait, typically associated with pernicious anemia due to the lack of proprioception and depth perception. This is a severe cognitive symptom of pernicious anemia that occurs from the lack of B12. When B12 is deficient, there's demyelination of the nerve fibers in the spinal cord and the cerebral cortex, which causes the loss of proprioception. And these are my references. Thank you for listening.